follow those guidelines, follow those guidelines and ensure that we are able to make the necessary corrections. I'd seen Mwangi's hand up at some point. I'm thinking that should be Mwangi. I'm not sure, from CDC. I'd seen your hand up. I don't know whether you had a comment that you wanted to make before we begin, because at this point, I want to request Moses to take us through the HTS workflow, where you'll be able to talk about the eligibility and testing for HIV, and of course also talk about PrEP eligibility. And then after that, Moses, I'll request that you hand it over to Frida, who will now be able to just talk about the issues around enrollments, the initiations, and then after that, Ogutu will talk about the ETL process. I think I'd already mentioned that. And then finally, we finish up with Mary. Because of time, I would really want that we make our program flow that way. And then now I'll come in after Mary is done with data review. We'll be able to take any questions. So in case you have any questions, please, we have a team here who will be able to respond to any of the questions you have as we are doing our presentation. So utilize the chat. And of course, we will also give you an opportunity to verbalize any, or to ask further questions, just in case we will not be able to, or you're not able to type. But I would request that let's utilize the chat and type or post our questions there. The team here is available to be able to respond to those questions. So at this point, I want to request Moses to take us through the first part of the presentation. Moses, over to you.
Thank you, Songok. Please confirm that I'm audible once more.
Yes, Moses, I confirm you're audible. And before you come in, Moses, we recognize and appreciate the presence of our colleagues from DOS, our colleagues from CDC, and our colleagues from Department of War. So we will give you an opportunity towards the end of our presentation to just make some quick remarks before we close. Moses, over to you.
Thank you. Allow me to share my screen, and for starters, to remind all of us on, to me it's more of a reminder, because I'm sure all of us are aware of this, or if you are not, probably, this is the first time you are probably interacting with the PrEP program, then I just want to take us through the PrEP eligibility criteria. So in Kenya, the pre-exposure prophylaxis eligibility requires that an individual, one, tests HIV. Sorry about that. So in Kenya, the PrEP eligibility requires that an individual tests, one, HIV negative, two, is that they are aged 15 years and above or older, so to say, and that their weight is at least 30 kilograms. So they should be weighing over and above 30 kgs. And four is that they must be facing a substantial ongoing risk of HIV exposure. So
Moses, we're not able to see your screen. I don't know that it's my end, but we're not able to see your visuals.
Oh, you're not able to see my screen? Let me unshare and come back again.
Yes. We are not able to see the presentation.
Yeah, let me share again.
Oh, yeah.
So confirm that my screen is up now.
Yes, it's now up. Thanks.
Well, yeah, this is what I was talking about, just taking us through the PrEP eligibility criteria. So I spoke about the five pointers, which are: one, you must be HIV negative. I talked about the age, which is you must be above 15 years old. So anyone below that age group is not eligible. And then they should be weighing at least 30 kgs and above, and facing a substantial ongoing risk of HIV exposure. Lastly, expressed your willingness to take PrEP. So those are the five eligibility criteria. Even as I enroll probably through HTS, and just show all of us how the system has been designed to be able to accommodate the 5 criteria. So allow me to switch my screen once more and now go to an instance of the EMR. So allow me to share this. So I'm going to confirm that what you are seeing now is an EMR.
Yes. I'm seeing an EMR. Continue.
Thank you. So in the interest of time, I decided to just enroll a client and just we don't waste time again with the registration and enrollment. What we have already is a client that I have enrolled, and I decided to name them my PreP clients. I can hear some feedback. I don't know from where, but probably someone should assist with the muting that particular participant. I'll want, for the purposes of us to just get the entire workflow of a PreP client, I'll request that you allow me to check the patient in retrospectively. So I'll check them in actually 1st of February. Just proceed, yeah. I'm sure they're checked in on 1st of February so that you are able to go through the entire cascade. So I talked about the 5 eligibility criteria. One, I'll want, first of all, probably to just ensure that my patient is HIV negative. How do we do that? I mean, we have to subject them through a HIV test. So the EMR, just as has been the case, from your clinical forms, you should be able to find your the HTS eligibility form, eligibility screening form, which is usually the first form that we fill for before we can perform any HIV testing and counseling services. So I'll maximize this so that you can all get to see. My population type, I'll want to just make my patient, my imaginary patient, a key pop, so that we can also score all the points, and that they are a female sex worker with no offense intended. And then I'll also want to say that they have no disability, because this is one of the things that it is out for, and that they are coming in as they're coming in from outpatient, so they're going to be they're coming in from OPD. So patient type for me will be hospital patient, and then client healthcare. Well, is a client a healthcare worker? I'll say no. Client has any relationship with an index client? None that we know. And then the HTS strategy is I'll make it provider initiated. And then the entry, let's make it it's a minute, my screen has. And then now for the entry, for the history of HIV testing, the client has, okay, they have tested before, but this was performed by a healthcare provider, and this was about 12 months ago. They were negative for that instance. So this was done, let's say 12 months ago. So I'll take it back to 2025, let's say in May, on the 28th. And then, has the client ever had sex? Of course, they have said yes. And the client is sexually active. And the client has had a new sexual partner in the last 3 months, of course. And that's the partner HIV status is unknown. So they are not able to tell whether the status for the partner. And then I also want to tease out whether they have engaged in unprotected sex with more than one sexual partner in the last 12 months, and they probably say yes, and say that they have confirmed that they have had 3, they have engaged in sex with about 3 partners. Does the client engage in sex under influence of alcohol and drugs sometimes? So yes. And then have you ever had unprotected sex in exchange for money or other? She declined to answer. But then have you recently had an incident of condom burst? I'll also say that they decline to answer. Have you engaged in unprotected sex with someone you don't know the HIV status in the last 12 months? They said yes. And then have you had unprotected sex with someone who has non-HIV positive status? They also decline to answer. And then traditional non-medical procedures, sacrification, plastic tooth extraction, circumcision. For this particular indicator, I'll say no. Violence screening, probably just say no for now. Preventive care assessment. The client has confirmed that they have had an episode of an STI in the last 3 months. And that after we assessed them for TB, actually, we didn't find them, they didn't show any signs of TB, so I'll just want them to pass with that. Pregnancy assessment, no, they are not pregnant, and that they are not breastfeeding. And also for the eligibility and referral for testing, I'll say that from my opinion, they are, but I'll want also to get the HIV risk score, so I'll click on that button to just see what the system, the EMR points of them. And as you can see, the EMR has flagged them as a high-risk client. It is saying that this client has a high probability of a HIV positive test result. So test is strongly recommended. So for that particular reason, I'll also recommend them for HIV testing. So I'll tick yes. And the reason why I'm recommending them is based on the machine learning risk category, and that I'll refer them for testing. So I'll save that particular form. Save it. Sorry, I missed out on something. Allow me to fix that. So see where the problem is. So they came in from OPD. I think that I got last, that missed out. So by so doing, I shall have filled the HTS eligibility assessment form for the patient. And as you can see, the patients have ticked all the right boxes for us to subject them to a HIV test. So I'll quickly just offer them an HTS initial test. So I'll fill this form and quickly just fill it so that we can get an HIV negative result. Why? Because it is one of our eligibility criteria. My server seems to be hanging, but we'll just allow it to populate. So the population type, again, like I said, they're key and vulnerable, and they are FSWs. They do not have a disability, with a HIV testing history of 12 months ago confirmed, and that they have not had any self-test in the last 12 months. The setting is testing will be done in a facility, and the approach is again provider initiated. And the HTS strategy, our HTS strategy again will be provider initiated. And I'll say that the HTS entry point is from OPD, and they have no signs of TB, and that we are going to perform, they have consented to a HIV test, and they are testing as an individual. So currently, our algorithm for HIV testing requires that, we subject such patients through a TRIM screen. So I'll offer them that test with the batch number that I've populated. And the kit has an expiry date of, let's say, 30th September, and that the HIV result is HIV negative. The final result is given to the patient, and as you can see, couple is discordant. It has marked itself as not applicable because we have specified that they have come in as individuals, not as a couple. Client referred for other services, I'll say yes. And based on the history that we've picked from this client, we will want them to just attend some risk reduction counseling, safer sex practices also, to be cancelled on that, and also pre-exposure prophylaxis, of course. And also I mentioned something to do with the STI covered in there. So I'll just want to save this particular form and now move on to the next forms that will help us meet the other criteria. So far, we have met about 2 criteria. The first criteria we've met is for the age. Our client is aged 36 years. And the second criteria we've met is that from our screening, even the eligibility screening, our client is posed a substantial risk, but that is not enough. We shall also have to do that. We shall also still have to do a PreP behavior risk screening. But before that, I want us to address the third of the weight. So how do we address that? That means that we have to feel for them, take their vitals and just feel for them so that we're able to get their weight, which is a critical component in allowing us to be able to access the PreP enrollment form. So patient having complaints today, I'll say no. Patient mobility, they came in walking. This is the new triage form. Any injury to the patient within the past 48 hours, I'll say no. Patient level of consciousness, they are very alert, and that these are their vital signs. Temperatures of 36.5. We've used a thermogun to get that, a pulse rate of 71, and systolic blood pressure of 115, which is within the normal range, and a diastolic blood pressure of let's say 79, again within the normal range, and then a respiratory rate of about 18, and oxygen saturation of 97, and room air. They are not on supplemental oxygen. So their weight is 67 kgs. They are weighing 67 kgs. So they have met our criteria with a height of about 167. Let me make it 174. Okay, so even the BMI is not outside the range, but a BMI is not an issue. So nutrition status, they have scored, they are within the normal range, and their LNP was on the 1st of, sorry, as I checked where later in February. Let me just take it to somewhere around January there about. And then, as you can see, they have a very good T score of 1, which means that they are stable patients, and therefore they will not require any emergency or preferential services for in matters of prioritization. So I'll save the form and proceed. So we have met the criteria number 3. So how do we meet criteria number 4? So there was also the bit of willingness and the substantial risk. So to reinforce those 2, I'll have to fill the PreP risk assessment form. So risk assessment form. So the PreP behavior risk assessment in the last 6 months. So this is the form that we fill. So this form helps us tease and just be able to ensure that our patients or our client passes that particular test or fail, depending on how you want, how they'll present themselves. So one is it's seeking to establish the behavior risk assessment for their partner. I will say that their partner is of a non, we don't know their status, the HIV status. They could be high risk partners for some reason, and that our client has sex with more than one partner, and that they're also engaging sometimes in transactional sex. They have also had a recent history of STI, so I'll also check that box, and that they have expressed that they have had some inconsistent or no condom use history in the recent past. So I think those 4 are enough for me. Our clients are on contraceptives, and that the assessment outcome is the risk. They are of a high risk. A risk education offered, yes. And then client willing to take PreP, they have accepted. So the willingness bit has to be taken from here. Like, remember I said one of the criteria again is other than just a substantial high risk, they must also be willing to take PreP. So that's so I've managed to score the last two criteria using this form. That is of showing that our client is at a high risk, and that two, they have expressed their willingness to take PreP. So I will refer them I'll indicate the services that will refer them to, and for the purposes of this, we'll want them to just take some risk reduction counseling, and it also taught on safer sex practices, and any other thing that probably we'll want to also capture. Let's say substance abuse and mental health treatment, and also because they showed they posted they posted a history of STIs. I'll also refer them for prevention and treatment of STIs, and then save this form. So after having accomplished all that, if I come down to my care panel and now the program enrollment, as you can see, currently there's no PreP enrollment as one of the modules available. But allow me to just refresh my page for the changes to take effect. And then we review that again. So when I come down to the care panel, and under program enrollment, PreP is one of the programs that is now available for enrollment for this particular patient. So I think having done that, that shows that I've already met all the criteria that I had stated in my opening remarks, and I'll want now to hand this over to my colleague, Frida.
Thank you, Moses. Confirm you can hear me?
Loud and clear. Allow me to share my screen.
Okay. Okay, I'm hoping you can see my screen. Moses or Franklin, confirm?
Yes, Frida, it's feasible. You can proceed.
Okay, so I'll be proceeding with the client that Moses was demonstrating with. So we're just going to show the full workflow from when they come into the facility and they go for eligibility screening, and then they're tested and they turn positive. And then, of course, having taken vitals and anthropometrics, and ascertain that the client is surely eligible for PreP. Then, as Moses has also taken us through, the enrollment program you'll be able to enroll the patient into PreP. So the fact that our patient is already eligible, when you click default, see the PreP module, will not be able to see the PreP program instances where I've gotten even calls from the facility. Note of the eligibility criteria that has been highlighted by Moses for you to be able to see the PreP module popping up. So we're going to proceed to enroll our client into the PreP program. So we'll enroll them. The client came on 1st February. We'll want to continue with the same visit enrollment. So I'll say continue. Then I come here and now enroll the client. So you can see the date is for 1st of February. So right now we're able to also RD in the system to be able to not only enroll PreP, but even capture RD information for programs such as HIV. So I'll save. So my client is enrolled into PreP program. You can be able to see the notifications. You can also tell status for the PreP program is enrolled. Now, initially we click on the clinical forms to be able to access the PreP forms. right now, we've made it easy for you. You'll just click on the 3 dots options and you'll be able to get the next form that you're supposed to complete for this patient who is enrolled in PreP. And that applies for all the other service areas that are here as well. So the next thing after enrollment is the patient is supposed to be initiated in PreP. So PreP initiation, and then we're going to complete this form. So a patient came on 1st of February, they've been tested, they're eligible, they've been enrolled to the PreP program. So now we are doing the initiation. This is as per the PreP workflow. So we're going to say the client is new. Again, you'll be able to specify whether the client is a transfer in or the client is restarting PreP. So we'll say the client is a new patient. Then we'll also specify the general population for the client, whether they are general POP or key POP and vulnerable. So I'll say our patient is a general POP population. Then you'll put the unique PreP number. I'll just put a number. Okay, then I'll proceed and say, if the client has previously been on PreP. So if the client has been on PreP previously, so the system will also tell you whether the unique number is invalid. Normally it consists of the MFL code, 4 digits, 4-digit here, and then it contains the 5-digit client number. So let me see. So mine has the MFL code, and then 2026, and then we have a 5-digit number. So I'll remove this last two. Yes. So if the client has previously been on PreP, you'll be able to specify the type of PreP they've previously been on. If they've never been on PreP, you'll say no. And then if the client is willing to share details about their adherence body, you'll click on add, and then you'll be able to put the name of the body. Maybe just say PreP body. Then I can say Lias is a mosh, that is our client was a female, so I can say that's their partner, and then I put a telephone number. And then if they have an alternative telephone number, they'll be able to provide, and then you add. So if they're, if they're willing to provide details for more than one body, then you'll be able to add. You click add, and then you add another body. So once you've done that, you'll scroll up, just confirm that the details that you've captured are correct, and all the fields that are mandatory that has or have asterisks have been completed. Then you proceed and save and close. So once you've done you fill the PreP initiation form, then the next form, you'll still be able to get it in the same place. Under the program name, PreP, the 3 dots, you'll be able to see now the form that will pop up after the initiation is the PreP clinical form. Previously, we had 3 forms. We had PreP initial form after initiation. We had the PreP follow-up form with the previous workflow where you'd come back after 1 month and then they fill the PreP follow-up form. And then for the next 3 months, they fill the monthly refill form. All those forms have now been collapsed into one form that is called the PreP clinical form. So that is the form that you'll have access to. Even if this patient goes and comes for the next visit, this is the form that the facility users will be able to complete. So this form is available here. If you click on clinical forms as well, you'll be able to still access the PreP clinical form. So I'll have to check out the patient and check in, then you'll be able to access the form. But for now, when you click on options under PreP, you'll be able to get it. So I'll click on PreP clinical form. So when the form opens up, then the first part is on screening. So you'll specify whether the patient has been screened for STI. So if they've been screened for STI, then you'll be able to select the outcome. So maybe I'll just say they've been screened for STI, but they're okay. They don't have STI. And then you'll also fill in the fertility intention part. So if they've attained menopause and you say yes, or you say no, then if they are not in the menopause stage yet, then you'll be able to specify the LNP date. Okay, so I'll say no. And again, remember this part is not mandatory. So I'll say no, but then maybe I'll just put a date. Okay, and then if the patient is pregnant, you'll be able to specify. I don't think I did it in the correct format. Let me just pick from the date picker. Okay, so if the patient is pregnant, you'll be able to specify. If they're pregnant, then you'll be able to also populate the expected delivery date. If they're not pregnant, then the next question is whether they're planning to get pregnant. Again, yes or no, you'll be able to specify. If they're breastfeeding, you'll also be able to specify. If they're on family planning, you'll also be able to specify whether they're on they're using family planning, or they're not using, or they want family planning. So you can be able to specify any of these. So when you say they're not using family planning, I think that's fine. When you say they're on family planning, you specify the exact family planning they're on. And then if you say they want family planning as well, you move to the next section. So if you say they want, then you specify the family planning they want. Then the next part is on the adverse drug reaction. So if the client is reacting to any drug, you'll be able to specify. So if you say yes, then you add what is the drug that is causing the reaction, assuming maybe it's chloroquine, and then you specify the reaction itself. I'm just guessing at this point, the reaction, and then you specify how severe it is. You'll be able to specify the date of onset of the reaction. Maybe the reaction started 6 years ago. And then the action that has been taken so far. So you'll be able to specify. If they have more than one reaction, you'll be able to add all the reactions that the patient is having. And then next we have the laboratory section. So if serum creatinine is done for the patient, then you'll be able to specify whether it's done or not. And then we have the PreP status, whether you'll be able to also specify whether there's been signs and symptoms of acute HIV. So you'll say yes or no. Again, remember when you say yes, down here by default, you cannot prescribe PreP for the patient. When the patient seroconverts or has signs of HIV, ideally they're supposed to go and get tested before you proceed to give them PreP. So you'll be able to specify. If the adherence counseling has been done for that visit, again, you'll be able to specify. And if you say adherence counseling has been done, because of the first visit, you'll be able to document the adherence outcome. And if fair or poor, then you can be able to, again, specify maybe first visit. And then if there's any contraindication for PreP, again, this is where you'll be able to specify. If there's none, you say none. If they've been tested and they have HIV positive, then you'll be able to also specify. Again, remember, you cannot be able to prescribe PreP if they're HIV positive. Same case with if they have renal impairment. Again, if they're not willing, be able to prescribe. And then if they're also less than 30 kgs. So I'll proceed and say no contraindication on PreP. So PreP prescribed, and then at the dosing strategy, you'll be able to specify which one is the patient being given. Are they given the daily oral one, or they're being given the long-acting PreP? So if you say the daily oral, then you specify the regimen. Then you proceed to say the number of months that they will be taking the regimen, and then you proceed to prescribe the drugs. If you say they're being given long-acting PreP, then you specify which one it is. For example, if it is lenacapavir, then you say they're being given for how many months? Normally, I believe it's for 6 months. And then you proceed and you prescribe the drug. So I'll proceed and prescribe the drug. So I'll say drug order lenacapavir. So I'll order lenacapavir tablet. Again, remember we have two. We have tablet and injection. And I believe the patient is given tablets for the first 2 days, and then they'll be given injection that lasts for 6 months. So you'll be able to specify here, assuming the patient is being given 1 tablet or to be taken orally once daily. And then you can say this is supposed to be, duration is supposed to be 2 days. And the quantity to dispense will now be 2 tablets. Refill is 0. And maybe indication is PreP. Okay, and then you can proceed and also add to your pinned order so that next time when you have another PreP client, you don't need to fill in the details you filled. When you go to try and order again, that prescription will be available. So if, for example, you come here to add another drug, lenacapavir will already be here. So you'll just click on it and proceed to save. That is a new feature that we've added in the current version of the EMR. So once you've prescribed, then you'll proceed and sign and close. Then you'll come back to the clinical form and then specify the PreP status. Remember, this is the first visit. So we're starting the client on PreP. Reason for starting the client on PreP, we'll be able to select depending on the reason that the healthcare provider sees fit, whether the sex partner was at high risk and the HIV status was not known. We'll be able to select whatever is applicable. So I'll select this one for now. You'll be able to also say whether the condoms were issued, and if condoms were issued, you specify the number of condoms that were issued. Then you give them the next appointment. So client given next appointment, yes. Then you click on add appointment, and then you specify the service. So the client is supposed to come back for PreP. The appointment is scheduled and they're supposed to come back after 6 months. So you'll specify the dates after 6 months from today. December. So assuming the client is supposed to come back on 31st December, you'll select the date. And then for the version that we have, the version that you currently have, there's a place here that used to allow you to select all day so that you don't have to specify the time and the minutes. But right now, the version that we have requires you to put in the minutes for the form to be submitted, but it's something we're working on. So you can also see from the calendar how many people have been scheduled to come on that day for that specific service. So as you can see on 31st of December, there's no one booked for that day. So I'll proceed and save so that you see that the duration is required for you to proceed to save that form. So it will tell you that you literally have to put minutes. So if you see this, just put any minute for now, but it's something that we're working on hopefully before the package is available to the team. All right, so once you've given the appointment, if the doctor has any additional notes, they'll be able to write the notes under the clinical notes, and then they save and close. So that is the PreP clinical form. So if this patient comes for the next visit, again, the providers will be able to get the patient from the queue as usual. I want to refresh so that we're able to see how to handle the patient when they come back. Let's give it a minute. Okay, so when the patient comes back, Again, the only other form they'll be able to access until they're discontinued is the PreP clinical form, as we had mentioned previously. So the clinicians will only fill the PreP clinical form until the client is discontinued from the PreP program. So the next time they come again, they'll click on PreP clinical form. Assuming this is now a new visit, I'll have to check out the client. Oh, someone has checked out my client. So I'll check in the client. So assuming the client has now come back today, so I'll create a new visit. I'll say the client has come and queue them in triage OPD room 1 and then start the visit. So when you click on PreP again, you'll be able to have access to the PreP clinical form. Okay, so yes. I'm having trouble scrolling down. Just give me a second. So the form remains the same. The only part that is different now is I'm not able to scroll. Let me just discard it and open it again. Okay. So yes, so the form remains the same. We'll be able to document everything that we documented previously. But now, let me just fill the form so that you see the part that is different. So the patient has attained menopause. The client is not reacting to any drug. Serum creatinine has been done. There's no signs of acute HIV. Adherence counseling has been done and it's good. And then we say they don't have any contraindication. And then we say they're supposed to be given long-acting PreP, still lenacapavir, for another 6 months. And then we prescribe, and then we proceed to continue with PreP. So you'll still fill the clinical form, and you'll still be able to give the client an appointment if you say yes, and you'll still be able to issue condoms, and it's the same thing. Once you're done with that, assuming you want to see, or a different doctor now wants to see what was done to this patient previously, you'll click on the clinical encounter to be able to access the historical information that was filled for this patient. For patient history, this is mainly for the clinical encounter for OPD that you'll be able to get historical information, anything that was filled in the clinical encounter form. But for other programs, you'll have to click the visit to access that specific visit that the client came. Give it a second to load. So you can access the visits, or you can access all encounters, still comes with all the forms. Then you can click on the down arrow. You can be able to review what the clinician or the doctor filled for this client when they came for that PreP visit. If you want to edit this information, you can proceed, click on the 3 dots, and you edit the encounter. If at all you need to make any change to whatever information you captured for the client, you can click edit, make changes, and then you proceed and save and close. So that is basically it for the PreP workflow currently in the EMR. If this client is supposed to be taken to, for example, a procedure, this is not really PreP, but it's part of what we've actually enhanced in the EMR right now. If at any point the client is being taken to a procedure, you'll click add procedures. You'll search for the procedure. Let me say stitching. Just from the top of my hand. It's taking a bit of time. Let me see if I can change my connectivity.
Moses, seems like or if she's speaking, I can't hear her.
The last she was fixing her connectivity.
I think it's taking a bit of time to order for procedures, but maybe I can just talk through it. So currently we've been able to configure. So right now we've been able to configure the system such that when you're ordering for a procedure, oh, it has loaded. You can be able to queue the procedures so that people are going for main.
Your screen is not up.
You may need to reshare your screen.
Oh, apologies for that.
It's okay.
Can you see it now?
It's loading, I guess. Yes. Proceed.
Okay. So my procedures are also loaded. So we've been able to work on the queues for procedures such that you can be able to queue people going for minor procedures and major procedures. If your facility, you have the theater that does minor procedures and also theater that does major procedures, be able to queue your patient. Your surgeons can be able to tell how many patients are actually queued for procedures on a specific theater. So they can major and minor, all from the queues. So how do you queue your patients to projecting? I'll say whether the operation is minor or major. I'll select the priority, maybe it's an emergency. Select the body site, maybe stomach. Number of repeats, if any, these are mandatory fields. Frequency, how many times is supposed to be done? Again, not a mandatory field. And then you say the order reason. Again, you can put anything there as an order reason. If you have any additions you need to complete also, you can be able to add and then comments to fulfiller. These last sections are not mandatory, but you can be able to add. Then we have the move to procedure queue. This is where now you queue your patients. So the current version that you'll be getting, if you want to queue your patients to the procedure, using this part of move to procedure queues, your patients will not be visible when they go to where they're being done for procedures, whether it's at the main theater or the minor outpatient. It's normally called the outpatient surgical minor surgical for oh yeah, that one, the surgical operations done at the outpatient. So you'll be able to specify the location. When you click on, you'll close the location that will be available there. Then we've also made it possible for you to search. So we noticed that there are some big facilities that have so many locations that scrolling down is a bit of a problem. So you can actually, be urgent or emergency, or if this is something that is normally this is routine. Emergency, if there are any comments you'll be able to put, then do that, then you come back and you save order, and then you sign and close. So when this patient goes for procedures now, you go back to TaifaCare, and then you click on procedures. You'll notice that now we have the patient under procedure room 1. If you click procedure room 2, we have no patients. So all the patients would have been queued in procedure room 1. You'll be able to find them down here. And these are customizable. So in your facility, you can even decide to call this minor theater and procedure room 2 major theater or main theater. So you'll find them down here, and then you can proceed and do procedures for the patient the way we normally do on routinely. So that is the other thing that has also quite changed. Just one last thing, with the version that is coming up is the patient visit summary. So right now, as the doctors document or see patients, especially at the OPD, you'll be able to also see the notes that are being filled in the clinical encounter populate. So we'll be able to see the vitals for the patient. So this summary is, you can be able to filter depending on the date that you're interested in. Assuming the patient has been coming here more often, you'll be able to have access to all the historical visits like we can see for this patient. So if I click on, for example, information for 1st of February, yes, like this one is. So if you click on information for a specific date, you'll be able to get a summary of what was done to that patient. So this is what I documented. It's coming up like this because this patient was seen in a program. But if the patient was seen at the OPD and the clinical encounter was filled, then the vitals will populate regardless of the program area they've been seen. Any procedure they've been sent to will also populate. Any laboratory tests that they've been sent to and the results will populate here. Any imaging orders that they've been sent to and results are available will populate. Any procedures as well. And then laboratory, we have pharmacy as well. You'll be able to see the pharmacy drugs that were prescribed for the patient. And if they've been dispensed, the status will also be able to show. So this part, this is one summary that is now visible per encounter. And you can even proceed and print the summary, patient summary at the facility point or facility level. So I'll now proceed to the reports for PreP. So we've also been able to consolidate the report, the PreP report. We used to have the initial and the follow-up. So right now we have one. It's called the MOH 267 PreP Daily Activity Register. If you generate that report, I had generated it earlier. You now will be able to see all the patients that have come for PreP. You'll be able to see their PreP dosing strategies and also the regimen and the status and the HIV results. Literally everything has been combined into one register that you can be able to use to monitor your PreP clients. So when you get time at the facility level, we'd also like you to try and generate this report. We know there are some cases where the report was not populating numbers. Please refresh your ETL and then not during working hours, after working hours, and then proceed and try and generate this report and see if your data is making sense. And then you can be able to reach out to us and give us feedback. Back to you, Franklin.
Thank you very much, Frida and Moses for the demo. I guess before we take any questions, I want to request Ogutu to take us through the next bit and then hand it over to Agnes. I think Mary has requested that Agnes would take us through the dashboard. So, Ogutu, I don't know whether you're ready. You can take it up. Is Ogutu in the call? Moses, confirm if Ogutu is still in the call, because I think he was supposed to take us through the mandatory configurations. I know Frida has talked about reports a bit.
Sungoka,
Yes, Moses. I can see him in the call, probably he can't hear me, but in that case, then can I request Agnes to take us through the dashboards meanwhile? Agnes?
Thank you, Songoke, and good afternoon, everyone. So allow me to take you through the above site PreP monitoring dashboard and what we have so far. And the period we will be assessing is since the inception of PreP, of lenacapavir specifically. So allow me to share my screen. Songo, kindly confirm you can see my screen.
Yes, I can see it's feasible. Proceed.
All right. So I'll just briefly take you through what you get to see on the PreP monitoring dashboard. So on the left side, there's a provision of several filters that you can use to get the specific data that you want. So you have the option of selecting a period. So for now, I've selected the period since March to date. Then you can drill down to any specific county that you would want to see their data, any sub-county facility. If you're interested in the sex, the age categories of the said patients, you have access to the same on the filters. And then finally, in the event that you want to assess any agency or end partner, that is also a provision under the filters. So what you get to see on the dashboard is first you get to see the total number of clients, and this is based on the data that has been pushed to the National Data Warehouse. And so far, for the period, we have received 31,352 clients. Then these clients are then disaggregated into how many were pregnant women, how many were breastfeeding women, and how many were started on lenacapavir. Just below that, you get to see the disaggregation of the said clients, the 31,352, by their dosing strategy, and you get to see that quite a number, like 62% of them are on the daily oral PreP. We have 36% of them on the long-acting PreP, and then we have quite a number, like 1.9%, on the event-driven PreP. Just next to that, you get a table that describes which regimen each patient is on. And for example, when you go to the long-acting PreP, you get to see the number that are on Kabele, the number that are also on lenacapavir. For the daily oral PreP, you get to see the specific regimens a patient is on. And then, as you can see, this table describes the patients that have either an undocumented regimen in the EMR or any undocumented dosing strategy in the EMR. And the reason for having these two columns is to assess the quality of the data that is being entered. And I'll get to how you get to see the patients who have undocumented regimen or dosing strategy towards the end of this presentation. Just below that, you get to see the distribution of the PreP clients based on the dosing strategy and the treatment plan. This is whether they are starting PreP,
they are switching PreP, they are continuing, restarting, or they have any undocumented variable. And then you get to see for Kabele how many patients started, how many switched, how many are continuing on Kabele, how many are starting, and how many have we received as undocumented. For Lena, the same. And just below that, you get to see the distribution by county and also the distribution by partner. Just below that, you get a facility list that describes the 31,352 patients that you can download in either a CSV or an Excel to do further analysis on. The new thing that has been added to this is we are monitoring the undocumented variables, and you get to see like a facility like Chibwai Mission Dispensary, what the percentage of undocumented treatment plan, the percent undocumented dosing strategy, and the percent with undocumented PreP regimen. So this can also be downloaded as a CSV or an Excel to help understand where your facility is at. And in order to be able to see at the facility level, who are these patients who have an undocumented PreP treatment plan or dosing strategy, you use the report that Frida has just shared, and that is the daily activity register. So allow me to change my screen and show something else. So I have downloaded the line list, the line list available in the facility in the form of an Excel, and what will show you the patients that have either an undocumented treatment plan. This is the dosing strategy and this is the regimen, is this. So you can see like this patient here with this PreP number has a missing dosing strategy. We have this one who is missing no, this is the regimen, sorry. And then we have this one who is missing a dosing strategy as well as a regimen. So the facility users should use this line list to help them inform them, the patients that have either a missing strategy, a missing regimen, or a missing treatment plan, make the necessary corrections. As Frida has also highlighted how you make the editorials in Kenya EMR, and the same will be uploaded to the National Data Warehouse, and the changes will be visible in the above site dashboard. That's it from me, and over to you, Songok.
Yeah, thank you very much, Agnes, for the walkthrough. I guess before we go to Q&A, I don't know that Ogutu, you can hear me now, because I want you to come in so that you're able to take us through a bit on the ETL process, then also to just talk about the mandatory configuration settings, and by extension, scheduler settings, and of course the mapping with the MFL code. So Ogutu, over to you.
Thank you, Songok. Am I audible?
Loud and clear, proceed.
Thank you. Let me just share my screen. Are you able to see my screen?
Yes, feasible.
Okay, thank you. So I'll be taking us through some mandatory fields on or configuration that needs to be done. First, for data to be pushed to the dashboard, we need to have especially data for PreP. We need to have the program monitoring scheduler. If you can see my screen, the program monitoring schedule is here. The one highlighted, if you're able to see. Okay, so the only advice that I would have or caveat you can have on this particular program monitoring for the sites, especially the ones that are on cloud and the ones that are running 24 hours, is to have the scheduler run maybe at night because it's a little bit resource intensive, and it's not only pushing PreP but also other indicators from other programs. So I would advise you have this running late in the evening or early in the morning or at night. So this program monitoring is the one responsible for sending PreP data to above site. And for your data to be mapped correctly on the dashboard, you need to have the global property for MFL code for your facility entered correctly. For my next tab, this is the property I'm talking about, the facility.mfl code. You should have the correct MFL code of your facility captured here. If in any case it's missing, that means that your data is just hanging somewhere. It's not mapped to any facility on the dashboard, and that is why you might be having your scheduler on, but when you go to the dashboard, you'll not be able to see your facilities data. So you have to ensure that this property is available, because we also are noted during our support activities. We noted that there are some facilities that are completely missing this particular global property. So if any case it's missing, kindly reach out to us via our contacts that I've shared on chats so that we can have it fixed and we have the correct facility MFL code updated. So for above site data that is being sent via DWAPI, you need to run your ETLs to ensure that the latest information that you captured for your clients are the ones that are being pushed to the national data warehouse, so that the facility has the latest information and the latest data that gives the correct picture of facility performance in terms of service delivery. So to do that, we provided the feature on the UI. You can access it from the homepage. You just go to the KNMR modules. You go to administration, and then we have the ETL administration here. So from the ETL operations, you can always use these particular features to recreate your facility ETLs before data upload or before pulling data from your register or report. I think that is all from me. Thank you, and back to you, Sabo.
Yeah, thank you. Thank you very much, Ogutu, for taking us through that process of configuration, which is very, very, very important for us to have visibility of your data that is coming in from EMR. And that would also enable you to do some bit of validation, just a comparison of what you have at the facility and what you have above site. But if that configuration is not done correctly, and I think Ogutu emphasized the fact that you need to ensure that your MFL code is available in global properties. If not, then that is the unique identifier. Well, that's the only way we are able to map the facilities and be able to just link it to for purposes of data transmission from site to national data warehouse, which is basically above site. So at this point, I think I want to appreciate the team who've been available to respond to most of the questions on the wall. Thanks. I'll go to Mary-Ann, members who are available to respond to most of the questions. I know some were comments, and we really take that up. some more suggestions that we may need to consider in terms of our system to make it. And I keep saying that inputs are very key, because that will build us. That is what would enable us review and transform the system to your liking. And at the end of the day, then that would enable us be able to just focus more on managing our clients. So we would really wish that you keep giving us some inputs and suggestions to improve on it. So I really don't want to spend a lot of time going through the chat, because I think Marianne and Tim have been able to respond, but I can just select a few just in case they've not been responded to. I think there is a comment from Emmanuel Kaunda. I'll just read very quickly. There are some sites that have no internet connections, and for such sites, we configure short repeat frequency intervals for program monitoring schedule. However, every new Kenya EMR release resets those configurations to default repeat interval of 1 day at around 12 a.m. This affects the reporting rates for our support sites. Is it possible to avoid the resetting of the program monitoring schedule? Yeah, I think, Emmanuel, you can reach out to the team. They should be able to provide further guidance on how we can be able to resolve that. How do we restart program monitoring when it stops running? I would request the team to just respond. Can just take one more from Charles. The current EMR version does not have continuation bulletin, hence having challenges with filling one. I don't understand that, but maybe Miriam or Moses, you can respond. Yeah, I think those are the few that I want to sample. Maybe I can also just request, in case there is you have any other further questions and you want to verbalize, you can raise your hand. And as I do that, allow me to apologize. I know there's so many of our colleagues who either kicked out or are not able to join using the Zoom link, because I think we hit our maximum at some point, but we were able to share a YouTube link or channel, and we are glad that quite a number of our colleagues were able to join and follow our walkthroughs and our discussion. See, there's an hand from Leonard Okumu, so maybe Leonard, you can go ahead, and I'd request Moses and Frida to respond to some of the questions that you've already picked from the chat. So we have two. So we have Leonard Okumu and Dennis Odhiambo. So we'll start with Leonard. Go ahead.
So thank you very much for this presentation, which is also timely towards improving quality services in PreP point of care documentation EMR. So what I realize, what I want to make emphasis on. So normally in HTS, the client come, we do the testing. But I know first thing that people usually forget, when a client come, actually the first thing we do is registration. Then the next thing we check in after, then also doing the triage. And that's why at some juncture now, we went back to the triage, and that's why it brought us now the PreP form. And that's why is the triage very important? It's very important because we have the weight, we have the anthropometric measurement being taken, and also vital signs being taken. And that's why I really agree that one of the things that is very important in terms of the PreP as to manage client or to document now appropriately, we must have the triage also done. So my word of encouragement to the HTS provider, we should ensure that those clients, once now we register them, and then during now the time of checking in now, we ensure now they have the triage, anthropometric measurement, and also vital signs documented. And that's why when now you go further to the HTS, you go now to the behavioral risk assessment now, and once you refresh now, you'll be able to get your PreP form. Why am I saying this? Because recently, when we were implementing this to some of our sites in the facility, they were not even seeing that PreP form. But now later on, they came to realize, most of the clients, they're lacking the weight, the anthropometric measurement. So it's very important actually when the client is coming, we ensure that even that before that HTS now, we do the we record the vitals and also the anthropometric measurement. Thank you.
Thank you very much, Leonard Okumu. Taking note of that, I think that's a very important observations to our HTS service providers to keep taking note, and we keep learning each day. So thank you very much for that observation, and I think all our colleagues who are in this call have also taken note of that, and we expect that we should be able to cascade to our other colleagues who are not able to join. That is really much appreciated. Dennis?
Oh, thank you, Songok, and thank you, Team Palladium. So my first rather question is, what has been done to the forms that were available through the clinical sections now that the workflow has been changed so that the clinical form is accessible through the enrollment section? Because in the previous version, they've not been archived. I don't know whether that has now been done with the current version. Then the second question, do I need to complete the HTS eligibility form for pregnant mothers or pregnant and breastfeeding mothers now that testing happens either through the NC, PNC forms before the PreP eligibility or risk assessment form is available for me? Has that one also been fixed so that I don't need to do that? Especially for the pregnant one, where it's obvious that when you're pregnant or visiting for the first time, you will have to be tested. Then the other request I have is on validating the initial form with the PreP clinical form, specifically the part where we have the client type as new TI and restart, so that there's no conflict when I've picked a restart, then I'll go back into the preclinical form and pick a start. Because I'm thinking if you already have a restart at the point of initiation, then I should not be having anything other than that in the inside form. Currently, they are not validated. Then that same variable on patient type or preparation type to be validated against the other question that asked whether you've been on PreP or whether you've been on PreP or not. Because in my thinking, I believe that when you're talking of new patient, then it means they are PreP naive. So the question around whether they've been PreP or not should not be there. But for the TIs and the restarts, then the question should suffice. Thank you.
Thank you. So just clarifications that you're seeking around eligibility screening for pregnant and breastfeeding mothers, and what have we done with the forms. So at this point, I want to request, I don't know whether it's Moses or Frida will go first and just respond to some of the questions on the wall, and then also take up what Dennis has raised regarding the old forms and screening, HTS eligibility screening for pregnant and breastfeeding, and then also the validation between initial and PreP clinical encounter forms. So, and I think from Leonard, that was just a comment, and we take that up. Moses, would you want to go first?
Well, Franklin, I think what I can comment on is that question about what happened to the forms that were initially in the clinical forms panel, all the PreP forms that were there. I can confirm that with this version, we have removed them there, so you'll not be able to find them there. So we expect it to adhere to what has been showcased here. I want Frida to answer the remainder of the questions.
Sorry, Moses, you're done. Sorry, I got distracted a bit.
Yeah, I'm done.
Okay. All right. So I'm not seeing any hand up, and I'm assuming that all the questions that were raised on the chat have been responded to. So I guess we should then be able to just come to the end of our meeting. But before we do that, I want to mention that there's something that maybe Agnes didn't mention. We through the CS port, I think you're able to see titles, you can also be able to monitor transmission of your data warehouse from the facility. So that's also a feature that we should be able to utilize every time that you'd want to monitor your transmission. Right. So Charles, maybe the last one before we close.
Yeah, thank you. Thank you for the wonderful presentation. Now, I'm having a challenge, especially filling in month 1 clients who come for their refill. And I ask this because when you go to the PreP encounter, the only chances that you have is for starting and for switching. So for month 1 who are coming, I find it a problem to fill the PreP encounter form. So I don't know if this time round this version has been corrected concerning that, so that we can fill in the correct values for our clients, because now I either say I'm starting a client or I'm switching, but you realize that it's a client who has come for month 1. So maybe that was my only concern. But again, if it has been fixed, then that is good. Well.
Okay. All right. Thank you, Charles. I know Moses only was able to respond to one of the questions. Frida, I don't know that you have any comments regarding what Dennis addressed earlier, because I feel like we've not been able to exhaustively respond to that. Frida, I don't know that you have any comments. Oh, Frida seems to have dropped. Okay. Marianne, maybe you can comment.
Yeah, thank you, Sangok. Good afternoon. On the question of whether we are still testing pregnant breastfeeding mothers, whether we are still doing eligibility screening for them. Well, eligibility screening is more of recommended for risk identification. So as much as it is mandatory for a pregnant or breastfeeding mother to be tested for HIV at initial contact and even at the different scheduled stages, it is highly recommended we also fill the eligibility screening form for them for risk stratification, for risk identification as well. Then for the suggestion that we validate according to the patient type, the newly introduced PreP form by incorporating TI, restart, new and ongoing, we're going to look at that and confirm whether the validation is working for all these categories. If not, then this is one of the things we can take as an enhancement request. Back to you, Samok.
All right, thank you very much. So I think we can close it at this point. Of course, in case you have any other comments or any other suggestions that you would want to enhance, you can reach out to us, and I will post my email address so that you can probably just share your thoughts. Post my email address here. And then I think there was also a concern about the continuation, especially for those who are on LEN-PrEP. I think that would be made possible once we clock 6 months from the time when we initiated the first client on PrEP. But then again, I think there was a concern regarding the same. It's related to the same on Kabele. So I think the team may need to relook at that, whether we have course Kabele is for a shorter course as compared to LEN-PrEP. So we may need to look at that and ensure that the enhancements enables you at the service delivery point to be able to indicate who is continuing or who is a restart. So I think that has been taken up. We will be able to check and ensure that that is factored in. So at this point, I want to probably maybe request a few members. I don't know that they're still in the call. I know I'd seen our colleagues from DOS, DOW, and CDC. I don't know if there's anyone from USG, please. Maybe you can make some quick remarks as we close, if you don't mind. Anyone from USG? I can't be able to scroll through all, but anyone from USG, kindly, you can take up the mic and speak on behalf of the team.
Good afternoon. Songok, I'm not sure who else from USG is here. I know Stella Njuguna was here at some point. I'm not sure that she's still here. So thanks a lot, Franklin, for convening us for this occasion. I'm Frederick Miruka from CDC. And so just thanking Franklin for coordinating us and convening us. Big thanks to Palladium for always supporting these processes and reviews. For any system that is being built, for me, I normally say is building the ship while it sails. And you built on what was existing, you have been identifying issues and addressing them. I also wish to give a big thanks to our colleagues who are working with the implementers and also our colleagues at site level, because indeed you are the one who are in direct contact with the program and carrying the heaviest weight in terms of program implementation. So for me, it's just thank you. And just saying that not everything is addressed and fixed as already presented. Most of them have been. And Franklin continues to coordinate a separate discussions just to continuously troubleshoot and address the issues with the different teams. Franklin, that would be all from my end, and just urging all of us kindly. I know there's one big area which I know is really holding us, is the lack of proper presentation of the very good work that you've done at site level. And because if you look at the number of individuals you have initiated, for example, lenacapavir and cabotegravir at site level versus what is on the dashboard, you'll see a very big difference, some even up to 50%. So we encourage you to constantly compare both and identifying where the bottlenecks are and addressing them so that your true achievement is reflected on the dashboard. Thanks, and back to you, Franklin.
Thank you very much, Fred. We appreciate the support. I know we've really walked this journey together, and we really appreciate. I want to, as we close on, to request one member from the county team, the CHMT, in the call. Anyone who is in the call, I think I'd seen quite a number, but I would just want to request one to speak. I may not really be able to point out who, but anyone who is ready to speak on behalf of the county teams, you can go ahead. Kindly, just 1 minute. Anyone from the county, CHMT, any CASCO, CHRIO, any sub-CASCO, sub-county HRIO is in the call? I can see Dr. Wagude. Daktari, I don't know that you can hear me. You can say hi to the team and just quick remarks on behalf of the county teams. Dr. Wagude. All right, so I guess probably maybe Doc is a bit engaged, but at this point, I want to request Ruth Kamau again to just close the meeting for us. But before then, allow me to appreciate you. Thanks for finding time to join us this evening. we really appreciate your feedback. Like I said, this feedback goes a long way in improving our system in terms of making sure that it's more user friendly, and of course serves the purpose that it was meant to. So from my end and on behalf of the SI team, the team is currently very, very engaged. There's so many other conflicting meetings, and that's the reason why they were not able to join us. But they are with us in spirit, and they're in support of what we are currently doing. Of course, being led by none other than Dr. Lily, who is the SI lead, Faith Ngare, Rosa Yuki. I know Rose. I think Rose had joined at some point, but it seems like she dropped because probably of other engagements. But we have their unwavering support. So from my end, thank you very much. We really appreciate, and I want to wish you a blessed evening. Ruth, maybe you can make some very quick remarks, and if you don't mind, you can also just close for us with a word of prayer. Thank
you so much, Songok and team, for the wonderful session that you've taken to us. And I believe you've shared the contacts where who the facility teams can reach out to in case they have any challenge. We hope to see that after these updates, the data quality will improve significantly. And with those remarks, I think we can say a prayer to just close the meeting. Let us pray. Heavenly Father, we thank you for this afternoon. Thank you for the task and responsibilities that you have given to each one of us. Help us and give us the grace to execute the duties to bring glory to your holy name. We pray for your protection and preservation. Pray for your provision in every need. In Jesus' name we pray and give thanks. Amen.
Amen.